The University
Recording
of the
in progress.
Philippines, the only Philippine university to be named in the top 100 universities in Asia. This state-run institution is a paragon of education steeped in history and culture. The University of the Philippines system is composed of 8 universities around the country. The oldest of which is the University of the Philippines, Manila, the birthplace of the UP system in 1908 in Padre Faura, Ermita. Its oldest unit, the Philippine Medical School, later renamed to UP College of Medicine, opened in 1905, followed by the Philippine General Hospital in 1907. From the College of Medicine evolved other colleges and units that diversified the university's course offerings. In 1948, UP was transferred to Diliman, Quezon City, leaving behind some health colleges and the College of Arts and Sciences. In 1976, the School of Health Sciences was created in Leyte to offer a community-based, ladderized health education that aimed to help increase the availability of trained health workers in the province. 2 satellite campuses of the school were strategically set up in 2 other remote and underserved provinces, namely Baler Aurora and Coronadal, South Cotabato. The creation of the Health Sciences Center in 1977 brought together all the health units under one roof. The center was renamed to UP Manila in 1983. Today, UP Manila is the recognized pioneer and leader in health education, research, and public service in the Philippines. Among its pioneering programs are university-wide BS Nursing, Master of Arts in Nursing, PhD Nursing, Master of Health Professions Education, Integrated Arts and Medicine, degree programs in Public Health, MD PhD, MA Health Policy Studies, MS Health Informatics, MS Genetic Counseling, PhD in the Health Sciences by Research, and the only ladderized midwifery, nursing, and medicine degree program of the School of Health Sciences. UP Manila's credentials have led to its being the partner of choice of the World Health Organization, Department of Health, Department of Science and Technology, Commission on Higher Education, and other local and international groups to achieve health reforms. UP Manila is the only campus in the UP system that offers education, research, and training in a wide array of health disciplines and professions. The university offers courses in medicine, nursing, pharmacy, dentistry, Allied Health Sciences, Public Health, Health Professions Education, Community Health, and the Arts, Natural, and Social Sciences. The competency-based curriculum makes it stand out among the other schools. Since 2014, in compliance with the Philippine Qualifications Framework, the colleges are now transitioning to Outcome-Based Education, or OBE. It enables the well-rounded development of students and unlocks their full potential as both health professionals and dedicated Filipinos. UP Manila educates the brightest students in the health professions and allied social science disciplines. Its students consistently top licensure examinations and assume positions of leadership and influence in government, the private sector, academe, non-government sector, and the community, giving them opportunities to shape national policies and programs on health. UP Manila is a pillar in the field of health research. UP Manila ensures that its faculty, staff, and students engage in research as a tool for health reforms, to enhance education and complement its public service role. With the help of the National Institutes of Health, the center of and coordinating body for all researches in the university, UP Manila's researches have served as basis for national policy formulation and program planning. UP Manila's firsts in health research and policy include Republic Act 9288, the Newborn Screening Act of 2004, RA 9709, Universal Newborn Hearing Screening and Intervention Act of 2009, RA 10747, Rare Disease Act of the Philippines in 2016. Other advocacies include the studies on liver diseases that led to the mandatory vaccination of newborns against hepatitis B, commercialization of Lagunti and Sambong as proven effective medications for cough and colds based on the results of the National Integrated Research Program on Medicinal Plants, the Ventilator Project, and the Vision Screening Project for newborns and school children. All of these for healthcare improvement. Strengthening this role is its public service function rendered through the Philippine General Hospital, its community and volunteer programs, and scholarly and technical assistance to the government, private sector, and civil society. As the Philippines' biggest government and tertiary hospital, the PGH sees more than 500,000 patients a year from all over the country. It trains thousands of health students and health professionals from within and outside the university. Among its innovative programs are on child protection and poison control and management. Volunteerism is strong at UP Manila. From the very beginning, students are ingrained with their role as public servants. Through the ugnayan ng pahinuod, faculty, students, staff, and alumni volunteers provide health and socio-cultural services that benefit depressed communities and indigent Filipinos. And to further reach out to the larger society, UP Manila offers the Community Health and Development Program and other community-oriented programs. This combination of excellent education, relevant research, and public service has produced thousands of exemplary doctors, nurses, dentists, pharmacists, public health experts, rehabilitation workers, paramedical workers, and more. With more than 100 years of excellent leadership in health, UP Manila is keeping itself nationally relevant and globally competitive by being at the forefront of Philippine health. The challenge may change, but UP Manila's response will be certain, excellent, relevant, and transformative.
Personally, HIV affected me from a personal level where I lost so many relatives to HIV when I was in high school.
I'm interested in how I can track and identify infectious disease outbreaks.
This summer, I got the opportunity to work on an adolescent HIV intervention in Cape Town, South Africa.
I wanted to dig deeper. I wanted to be actually part of the story.
Somebody had to do something, I wanted to make that change. I knew I have to do public health.
I was really interested in Brown because of their focus on learning public health by doing public health.
I like how there are many different research centers that allow different students to find what they're interested in, what they're passionate about.
One of the things that's different about Brown is we've got a lot of faculty and we don't have that many students. It's not that difficult to find a faculty member who's working in the area that corresponds to your interests.
So my first week here, my first class with Dr. Lurie, I asked him after class if I might be able to work with him, and he agreed. He's been helping me develop my research interest, and he's my thesis advisor now.
Brown was so open to allowing me to meld my work with my school experience. So it was going to make it possible for me to do both things at the same time.
What I love about Brown is the multidisciplinary, where it's not just one department. You can transfer and work with other members from other departments like epidemiology, biostatistics, health services.
I think there's several reasons that students choose to come to Brown. Of course, they love the idea of being able to design and to participate in the design of their own curriculum and their own experiences, learning by doing public health. And they have the whole university at Brown at their disposal to develop their skill sets and their knowledge base.
All of the professors are incredibly accessible, and a lot of them work in the field. So they're not just academics who have a conceptual understanding of public health, they're actually doing public health all the time. So they draw that experience into their lessons.
I think a central part of our philosophy is that students should be learning both in the classroom and in their hands-on experiences out in the real world.
And in the afternoons, I would get the opportunity to go out to local sites in the townships around Cape Town to see firsthand what all my learning in my classes was doing to have a positive impact on the people in Cape Town was something that was really fulfilling for me.
At Brown, we learn public health by doing public health.
I learn public health by doing public health.
I'm learning public health by doing public health.
We learn public health by doing public health.
I learn public health by doing public health.
The HIV COVID-19 webinar series is sponsored by the University of Philippines Manila, Brown University Training Program for the Prevention of HIV in Vulnerable Populations. This D43 HIV training program began in 2017, funded by a grant from the U.S. National Institutes of Health, Fogarty International Center. The HIV training program is led by Dr. Don Operario from Brown University, along with co-investigators Vice Chancellor Nimia Pimentel Simbulan and Laura Fred Hernandez from the University of Philippines, and Dr. Susan Ku Vin and Katie Biello from Brown University.
Before we begin, please be reminded of our house rules. Participants in our Zoom platform are requested to keep their microphones on mute and their webcams turned off. Participants may use the Q&A box for questions and comments related to the webinar at any time. Viewers of the FB live stream, Subselfie, and Reporter may also post their questions and comments in the corresponding platform's chat box. Our team will forward this to our session moderator. Our moderator will be reading a select number of these questions and comments due to limited time. We value respect and courtesy during our webinar session. Thank you. Welcome to the final session of the HIV and COVID-19 webinar series, presented by the University of the Philippines Manila and Brown University through the NIH Fogarty program. Our moderator for today is Dr. Angelina Mirasol, Clinical Associate Professor of the University of the Philippines Manila, Philippine General Hospital. Dr. Mirasol is an actively practicing adult hematologist of the section of hematology under the Department of Medicine. She was a former assistant head, OIC, of the section of blood bank and transfusion medicine of the Department of Laboratory and chair of the Hospital Blood Transfusion Committee of the same institution. She has served as an assistant director for chemotherapy and research and assistant director for service and training of the Cancer Institute of UPPGH. Dr. Mirasol, the virtual floor is now yours.
Good afternoon, everyone, and welcome to the 5th session of the 5th HIV and COVID-19 webinar series. During the first series, we had the COVID-19 and the HIV cascade of care. They had a discussion on the emergent challenges and innovative responses. Then on the second session, it was on the ground. They had discussions on the COVID-19 narratives and realities of the persons living with HIV community. Then the third was who is next in line. considerations and guidelines in vaccinating the PL-HIV community was discussed. The fourth session was on communities and COVID-19. They also had a discussion at the roundtable with community-based organizations. We are now on our fifth session. The five-part series highlighted the challenges that COVID-19 pandemic has brought to the HIV prevention and care continuum and the lessons that can guide HIV service delivery in the post-pandemic Philippines. Next slide, please. Okay, today's session is entitled Next Steps, the Post-Pandemic Philippine HIV Epidemic Response. The COVID-19 pandemic has caused as well as revealed major gaps and limitations in the current HIV epidemic response of the Philippines. In this culminating session of the UP-Manila-Brown HIV and COVID-19 webinar series, representatives from academic and research institutions and community-based organizations join policy and program implementers in sharing their perspectives, lessons, and recommendations on reimagining the HIV epidemic response of the country. The webinar is currently conducted via Zoom and live streamed in the UP Manila and UP Manila Brown Facebook pages. We are also being covered live via Twitter through the UP Manila Brown webinar, the Selfie, and Report.World accounts. Viewers of the live stream and followers of the Twitter accounts may also post their questions and comments in the corresponding platform's chat box. Next slide, please. Today's session objective is to determine perspectives, lessons, and recommendations on reimagining the HIV epidemic response of the Philippines post-COVID-19 pandemic from representatives of the government, academe, community-based practice, and research organizations. Next slide, please. We begin our session with a presentation of Ms. Maria Luisa Eresca, the current Executive Director of the Philippine National AIDS Council or PNAC Secretariat. She is the National President of the Philippine Public Health Association, the former President of Department of Health Chief HR's Association, the former Development Management Officer 4, former Chief HR, former Head of Internal Control Office, the former Health Program Officer 3, former Regional Health Executive Advisor of the Centers for Health Development of Metro Manila. Let us welcome Director Oresca, who will be discussing on moving forward in addressing the HIV epidemic through national and Director Oresca.
Hello? Hello?
Can hear you na po, Director Oresca.
Can you
with your students,
for a while, I'm having
especially
a
if you're a
problem,
math
Ryan.
teacher.
While we're still fixing the first presentation, can we first go to the second? Director Oresca? Okay,
Yeah, my apology, please.
Okay. So our next presenter is Dr. Reynaldo Imperial, the former Dean and Professor of the College of Arts and Sciences, University of the Philippines, Manila. Dr. Reynaldo Imperial finished his degrees in Associate in Arts and Bachelor of Arts in Philosophy at the Pamantasan ng Lungsod ng Maynila, Master of Business Administration degree and Doctorate in Philosophy major in Philippine Studies, Anthropology, History, and Psychology at UP Diliman. He has recently completed all academic requirements for the degree of Master in Health Professions Education at the NTTC UP Manila. He received his postdoctoral degree in history from the Georgetown University in Washington, D.C., USA, and his HIV epidemiology training from the Brown University. He has attended several major training programs, such as the Fogarty Research Course in HIV and AIDS, and Fogarty AIDS Training and Research Program at Brown University, and Ethical Issues in International Health Research course at the Harvard University in the United States. He was a European Union Scholarship grantee to the Planning for the Social and Economic Impact of HIV and AIDS, a policy research workshop at the School of Development Economics, University of East Anglia, United Kingdom. Professor Imperial will be discussing on moving forward in addressing the HIV epidemic through education and research. Let us all welcome, he will be presenting his video presentation.
Magandang araw po sa lahat. Salamat sa organizers sa pagkakataong makapagbigay ng panayam na ito. I'll be presenting various scenarios, yung mga magandang tanawin tungkol sa HIV at sa AIDS and the research gap and opportunities which can help mitigate the spread of HIV and the COVID pandemic. Scenario 1. Research and implementation of interventions will only be significant if findings can be applied by healthcare providers in various institutions and settings. So balit alam natin ang mga ganito ay hindi lubos na nangyayari. Let us consider the research gaps in the behavioral and social sciences. Gap 1. Strategies are needed to transfer research-based HIV prevention methods to providers of HIV prevention and treatment services. Active collaboration between researchers and service agencies result in more successful programs. Gap 2. We have to know the best ways to translate research findings in the treatment and care of PLWHA. Gap 3. Dissemination efforts to rapidly move science-based programs to the field will require significant funding in training and consultation, without which service providers are unlikely to benefit from the scientific advances now being made in the field of HIV prevention and research. There's several factors to this. Number one is that research are published in journals that are not often consulted by CBOs, AIDS service organizations, and other healthcare providers. Scientific articles describing the outcomes of research-based HIV prevention methods do not typically present intervention procedures at the level of details needed for agencies to implement. Methods need to adopt research-based HIV prevention interventions to local community needs, tailored for different populations. Now let us go to specifics. Scenario 2. The HIV epidemic in the Philippines has been rapidly changing and expanding in the past 5 years. From a low and slow to fast and furious epidemic, the number of diagnosed HIV infections has increased dramatically to 29 to 33 cases a day, 800 new cases for January 2021. The Philippines adopted the 1990 UN targets in the PNAC ANTP6 and the DOH National HIV AIDS and STI Prevention and Control Program, Health Sector Plan for 2018 to 2020, and the Republic Act 11166, an act strengthening the Philippine Comprehensive Policy on HIV and AIDS, enacted on 23 July 2018. This commitment specifically ensures that 90% of PLHIV are given uninterrupted antiretroviral therapy and provision of uninterrupted supply. ARVs are accessed by PLHIV at 51 DOH designated treatment hubs strategically located across the country. Strategic use of ARV is one of the key strategic areas outlined in the Philippine Antiretroviral Therapy Implementation Plan 2017-2020. The thrust of the DOH is to decentralize HIV services, including provision of ART, and bring these services closer to the communities to ensure linkage to care and improved access to HIV services. The costed operational plan outlines various activities for the continuous expansion of ARV service delivery points, hope to contribute achieving the target of 90% of PLHIV will be started on ART. However, there are gaps in research targeting this concern. Gap 4. There is a need to improve the body of knowledge about HIV risks and transmission among key vulnerable population groups in the Philippines, like MSMs, PWD, and transgenders. There is a need to understand the transmission link factors and the structural, social, and behavioral factors impacting on these groups. Gap 11. It remains unclear whether existing prevention interventions are adaptable or require distinct design for this national context. Gap 6. Most of the studies identified in this review use cross-sectional surveys with convenient sampling involving mostly descriptive measures, which limit the generalizability of the research. While these study designs are useful and exploratory investigations, it is imperative for researchers to increase the rigor of investigation by using longitudinal and experimental studies in order to examine more complex research hypotheses. Gap 7. The literature identified in these studies noted the scarcity of investigations into the psychosocial and ecological factors that contribute to HIV risk, mental health, personal and community empowerment, stigma, and substance use, among others. Gap 8, a multidisciplinary research agenda for understanding and addressing HIV transmission in the Philippines must span across various domains of research, including prevention, epidemiology, treatment, and behavioral and social sciences. Scenario 3. Ideally, a successful implementation and promotion of biomedical HIV prevention strategies necessitate healthcare workers possessing sufficient knowledge of positive attitudes, promotion of pre- and post-exposure prophylaxis, and intervention programs to include transgender communities based on science will have to be undertaken. Gap 9. Healthcare workers demonstrated awareness of PrEP, PEP, but raised logistic and infrastructural concerns about their implementation, which actually leads to some policy implications, like in order for PrEP and PEP to be feasible in the Philippines, public funding, provider education, standardized rational prescription protocols, guidelines, and policies are needed. Gap 10. Although providers were unsure about how to prioritize HIV services for TW and MSM, some expressed interest in learning and engaging these populations in their practice. The findings suggest the importance of provider-focused interventions to prioritize TW and MSM health needs and issues. Scenario 4. The HIV and AIDS problem continue to wreak havoc worldwide, with the heaviest toll being shouldered by the developing world. For the past 3 decades, the AIDS epidemic, considered by most states and governments as one of the most pressing problems of the world today, has had devastating impact on the lives, structures, and development of individuals, families, communities, and nations. This can be gleaned from the loss of productivity, erosion of incomes, rising costs of medical hospitalization and funeral expenses, premature deaths of productive workers and adults, decline in national investments and earnings, increased investments in HIV and AIDS, prevention, care, and support programs, and life-prolonging antiretroviral drugs, all of which are experienced by individuals, families, and governments. Gap 11. The connection between HIV and AIDS, development, and human rights has eventually led to an expansion of the response beyond the biomedical paradigm. Grounded in health and human rights principles, the global response to HIV and AIDS has put emphasis on the role and obligations of governments, the multi-sectoral approach, people's participation and empowerment as exemplified in the principles of greater involvement of people with HIV and AIDS, international solidarity and cooperation, and distributive justice. Scenario 5. Now let's go to COVID-19's implication to HIV research. The journey continues in search of HIV vaccine under this pandemic. Based upon the challenges that HIV biology presents, global sequence diversity, integration of the viral genome into the host cells, a long duration of the symptom, it is widely accepted that a vaccine must trigger responses that are qualitatively different from the immune responses to natural infection. In the recent development in the vaccine field in COVID-19, it is clear that much work remains to be done in HIV vaccines. Going forward, we must continue to engage communities to ensure a shared understanding of our common goals. While we pursue a safe and effective HIV vaccine, we are also seeking ways of improving chemoprophylaxis. Scenario 6. The COVID-19 pandemic presents multifaceted challenges to HIV service, CBOs, including but not limited to resource shortages, low staff morale, and disruption to patient-centered service provision. Gap 13. Despite the growing emphasis on person-centered care, few empirical studies have investigated the implication of person-centered care for organizations offering HIV services. Doing so should help researchers address the limited evidence on referral making and linkage practices that could help clients access the HIV services to which they are referred, and ultimately end the HIV pandemic within the decade. In conclusion, although global attention is dominated by COVID-19, the HIV and AIDS epidemic, as it enters its 5th decade, is far from over. Since the early 1980s, 75.7 million people have become infected with HIV. 32.7 million people have died from AIDS-related illnesses. HIV and AIDS remains a major public health crisis, and only a few countries will meet the 90-90-90 treatment target for 2020. Much has been made of how information systems and service models in the HIV response have helped the COVID-19 response. But the COVID-19 pandemic could have knock-on effects on the HIV response and be devastating for communities. How might the COVID-19 pandemic shape the future HIV and AIDS response and research towards reaching the goal of ending HIV AIDS by 2030? The integration of HIV with COVID-19 is already happening. COVID-19 has compelled numerous countries to accelerate the scale-up of differentiated service delivery for HIV by expediting multi-month dispensing of HIV medicine, which they otherwise may not have done. COVID-19 is impelling HIV services and forcing health systems to adapt. But adaptation need not always be harmful. Looking for opportunities to prioritize people-centered strategies could empower patients and help to address issues such as stigma, discrimination, and poverty through research, in addition to reducing contact with health facilities and so freeing up capacity. Such an approach is needed to rejuvenate the HIV response to end this epidemic. Maraming salamat po. Maganda.
Our next presenter is Mr. Benedict Bernabeu. Mr. Bernabeu is the President and Executive Director of the Red Whistle, a health and human rights organization. He obtained his Master of Development Studies degree from the University of Melbourne in 2012. He has been involved in HIV advocacy in the last 10 years, starting with his engagement with UNAIDS Philippines in 2010, and as trustee and officer of various HIV NGOs. He is currently pursuing his Juris Doctor degree at the University of the Philippines College of Law. Mr. Bernabeu will be discussing on the moving forward in addressing the HIV endemic through CBOs. Let us all welcome Mr. Bernabeu.
Hello, everyone, and good afternoon to my fellow ISCO and ISCA in UP. My name is Benedict Bernabeu, and I am the President and Executive Director of the Red Whistle. I just want to share my screen, if I may. Yeah, okay. Let's see. Right. So My presentation is about moving forward in addressing the HIV pandemic through the CBOs. To give you a very quick introduction to the Red Whistle, I just want to show you one of the projects that we've worked with in the last few years. Let me see. I think I need to share the audio again. Let me just do that again.
Quiet, please. So I'll just ask you some questions. Tapos, we have some words here. We're gonna give it to you. Try to read it. If you cannot, and if you're uncomfortable reading the words or phrases, just react to it. Like what we've mentioned, we're gonna air this on online and also hopefully on cinemas.
Try ko lang nga. O sige, game.
Ano ba to? Ba't ganito? Katakot naman to. Oh,
Teka lang, tawa ko doon sa letter K na word. Alam mo naman na ayoko tanaan. Teka lang.
Nakakaloka. Napaka-vulgar.
Ano babasahin ko? Ano ba yan? Totoo? Ito talaga yung una. Bakit ganun?
Nag-read ako.
Nangingilaw ko, te. Hindi lang, isa ako sa Ay, talaga inuna mo to. Nanadya ka ba?
Wow.
Can I just say... Ano ba yan? Basang-basa? Ano awareness? Ayoko kung ipaano.
Sabihin ka talaga. Pag mahal mo, pwede naman namang kainin to.
Ano ba to? Iyo! Big ko. Parang pa tayo talang pelikula. Kay Brosa sa pelikulang sa bibig ko.
You like this one? Nilolok ko niyo ako. Para sa akin ba talaga to? Parang iba yung napunta sa akin.
Teka lang, yung anak ko, ano ba yun? Naririnig mo? Yung labas yun na nga, nakakahiya.
Ang baboy talaga nito.
Meron I'm just clearing my throat, okay? Secret! Nag-ayos pa ako for this, ha?
Yes, friends. Totoo po.
Censored ang mga pinabasa sa amin.
Not like HIV.
Walang dapat ikahiya.
Or worth censoring about it. Let's talk about it.
Pag-usapan natin ito.
At huwag matakot magtanong.
It's okay.
It's okay.
It's okay.
It's okay.
It's okay.
It's okay. It's okay. Dahil it's okay.
It's okay.
All right, so this is one of our projects, which was funded by the Save the Children and the Global Fund back in 2017. As early as, or as late as 2017, a lot of people are still not comfortable talking about HIV in the Philippines. And we created a campaign to make talking about sex and HIV okay. And I think we've achieved a lot of progress in the last few years. Because of that campaign and because of many other campaigns that are pioneered by community-based organizations like ours. So the Red Whistle is a health, wellness, and human rights organization founded in 2011. We have changed our vision and mission in line with what is happening right now during this pandemic. We feel that HIV cannot be addressed if we silo the diseases into specific infections, but we have to look at it at a more holistic manner. So our strategy is to use social media, the arts, and the celebrity culture in the Philippines to increase awareness of sexual health and HIV. We do a lot of communication campaigns, and sadly, communication is overlooked in terms of resources and budgeting when it comes to health programs. But it's actually the first step towards achieving health when there is clear communication about the kind of healthy behavior that we want to elicit from people. The red whistle is a symbol of the need, not the new, but the need to sound the alarm on the increase of new HIV infections in the Philippines. Back in 2011, we were struggling with an increase in new HIV infections among our own friends and loved ones. And the situation has not improved in the last 10 years. So there is still a need to continue to sound that alarm. So during the pandemic, we've been doing a few things in response to the emergency situation. We are not a service provider per se, but there was a big gap in our treatment delivery, in our treatment delivery program. Because of the lockdown during the ACQ of March to May or June 2020, a lot of people were not able to access their medication, their antiretroviral medication specifically, because of the checkpoints that were set up between cities and provinces and even within barangays. There was a big fear of disclosure of their status, and a lot of the people living with HIV are not enrolled in the same city or town that they live in because of the fear of stigma and discrimination. They don't want to be easily identified by their own townmates or neighbors. So there are some individuals who are registered in another region or in another island altogether. In one case, we had a resident of Sultan Kudarat who was registered in Manila or enrolled in a treatment hub in Manila, who could not get their medication because of a lockdown in a separate city where the LBC store was. So we had to call on some city officials and provincial officials and the military just to help us get 1 month supply of ARV to one individual. And all of these have been volunteer driven in March and April. And then we received funding from UNAIDS starting May until the end of December 2020. Of course, we did not foresee that there will be another ECQ in March or for the second surge, and then this latest one this month. So there's still there are still barriers in terms of accessing ARV among the thousands of people living with HIV in various places in the Philippines. A part of our partnership or a part of the funding that we received from UNAIDS went into a partnership with Angkas, which allowed us to bring down costs of delivery to around 65 pesos per head compared to the usual 200 pesos per head per delivery if you do it one-on-one through LBC or other courier services. The second one that we did was the Condom Heroes Community Condom Pickup Project. So people did not stop having sexual intercourse during the ECQ. So it's important to make sure that they have access to condoms during the ECQ. And the condom pickup points or condom stops are of course location based, or they're not accessible to everyone. So what we did was to identify community condom heroes. So these are people in their barangays that you can meet up. You just have to register through our sign up form, and then we will match you with a condom hero near you. So this was piloted in Pasay City and Makati City, and it was funded by the UNFPA for the pilot study, and it was well received by the community. And I'll discuss what other implementation or sustainability issues we experience with these programs later on. We also have other programs like our HIV 101 campaign. So again, we use celebrities a lot in our visual so that it arrests the attention of people. It makes it more sexy, basically. And we also do our SOGI SE 101 program online. So we've been doing this for the last few months during this pandemic. HIV 101 should not stop because you have, people beginning their sexual activities even during the pandemic. So it's important to educate everyone. So our strategy is to go to partner with schools and workplaces where they have become Zoom natives in order to deliver an online HIV 101 and online SOGSE 101 program. And it has been well received. The cost is low because we deliver it online, so we don't have to go there physically. So we continue to innovate in this by making it more interactive and more gamified to make it more fun for university students, for example. We also did an emergency unconditional cash transfer to people living with HIV, people of diverse SOGI, and people with mental health concerns during the typhoons around the end of the year. I think this was around October, November. We saw that relief efforts were not reaching this target population. So we had an uncommitted cash sponsorship from one of our sponsors, which we utilized to give unconditional cash transfers to people who need it. So they can use it for buying their drugs, for example, their psychiatric drugs, for people with mental health concerns, paying for their therapists, buying grocery, and any other need that they have in general. And we don't ask for any receipt, we just give the cash to these people. And then finally, we have mental health program online, which is called Coping and Other Parenting. So it's basically a group therapy style mental health program that we initiated at the beginning of the lockdown in March and April. So of course, all of these are not really long-term programs that we have. These are more like band-aid solutions to really grave problems that we have observed in the HIV response. And our recommendation comes in the form of policy advocacy. So aside from these, actually, we also participated in researches during the pandemic. So for example, we did this survey with your program. We helped in disseminating information about the survey. And we also had tie-ups with other schools like the Ateneo School for School of Medicine and Public Health, the De La Salle University, UST, and the Ateneo graduate schools as well. So we used the opportunity of being online to help in the research, in increasing research participation. So as I mentioned, our policy, for the CBOs, our way to move forward is through policy advocacy. And we were able to do session with all of the community networks that are the community-based organization networks that we have in the Philippines just 2 weeks ago to talk about the themes of the policy recommendations and advocacies that we have lined up for this year and the next 6 years. So these policy recommendations are grouped together in 4 themes. The first one is to strengthen the PNAC in its inherent mandate in the HIV response. The second is to contribute to strengthening local HIV responses. The third one is the contribution towards resilient and sustainable systems for health. And last one is the research agenda in aid of our community agenda advocacy and HIV programming. I think Dr. Imperial mentioned some of these research agenda in the last presentation that he had. So let's me start with the inherent mandate of PNAC. So for those who are not familiar, we do have an HIV law, RA 11166, which mandates multi-sector response to the HIV pandemic. So the response should not just be a medical response, but there should be care and support. There should also be a legal response to prevent stigma and discrimination, and implement the criminal aspects of the law to make sure that there are no discriminatory behavior exercised in the Philippines. So here's a list of our priorities. The first one is to have a comprehensive organizational and performance audit of the Philippine National AIDS Council and its secretariat. And the second one is to develop a national M&E plan for the national HIV response. So we're not just talking about a monitoring and evaluation plan of the medical or the health sector response, but the whole response, including the legal framework, the redress mechanisms, the employment support, financial support, and all of the other services that should be available to people living with HIV. The third one is the translation of the UN high-level meeting political declaration, which was issued last June, and translate that into our our national and local policy and programs. The fourth one is to mobilize funding for the recently approved PNAC Human Rights Roadmap, which aims to ensure that there's a human rights-based response to HIV in every aspect of our multi-sector response. Part of this is to seek a PNAC resolution. Actually, these are more operational things, so I'll probably not discuss the operational matters. Still under theme 1 is to make sure that our next medium-term plan, so this is AMTP is the AIDS medium-term plan, which should be presented every 6 years. We have to make sure that our next AMTP 7, is rights-based, gender transformative, evidence-based, and costed, and has an operational plan to it. The sixth one is to mobilize resources to be allocated for CSO members in the representation work. So if you're not familiar with the PNAC structure, the PNAC is composed of government agencies and CBOs or CSOs. And of course, the CSOs are doing the additional work of PNAC from within their own organizational budget. So we're seeking support for the representation work that these CSO members do because they represent their sectors and not their own organization. Seventh is to advocate for increased domestic financing for HIV, including advocacy for PNAC government agencies to be allowed their own HIV budgets. So the multi-sector response requires that every member or every agency of the government allocates a budget for HIV and not just depend on the DOH budget for the HIV response. Eighth is to increase participation of key population communities in PNAC committee level discussions and allow them to observe plenary meetings of the National AIDS Council. We need to make sure that the voices of the key affected populations and people living with HIV are always heard in these policy-making bodies. So we are advocating for their increased participation. And finally, strengthen PNAC's capacity to address policies in conflict with the law, RA 11166. There are many One of them is the drug law, the Dangerous Drugs Act, or RA 9165. And of course, other laws that criminalize sex work and among other things. On the second theme, we want to contribute to strengthening local HIV responses. We want to align local HIV policies with the national law, RA 11166. We want to do this by reactivating or recreating the local AIDS councils that were present in the old regime of the old law, RA 8504, and align the existing AIDS ordinances to the new law. There are many ordinances created in the previous law that are now legally repealed because there's a repealing clause in RA 11166. We want to increase the number of seats for CSOs in these local AIDS councils, and we want to make sure that there's youth participation in these councils, and we want to look at ordinances that decriminalize aspects of the risky behavior that we want to address at the local level. Aside from this, we also want to advocate for LGUs to increase their investment in the HIV response. And this is very relevant next year when the Mandanas ruling takes effect, when the national taxes the LGUs will have an increased share in the national taxes. And we're looking at social contracting as a modality to help LGUs implement their programs through CSOs, CBOs, and other local organizations. So we have to advocate at the local level for LGUs to increase funding or allocate funding altogether. And of course, we want to advocate with the DALG to create guidelines to make sure that HIV investments at the local level are conducted in a way that is in sync with the national policy and the national law. The third theme is the contribution towards resilient and sustainable systems for health. I've already mentioned social contracting in the previous slide. We want to advocate for this at the national level as well. So make sure that there is enhanced HIV financing and sustainability by making sure that the funding comes from the government. PNAC to provide technical guidance to relevant government agencies to enhance the integration of HIV programs into the different programs. For example, we have existing programs on maternal health and programs for youth health. And we also have the rehabilitation program for people who use drugs. So we want to make sure that the HIV program meshes or fits well into those programs. Implementation of evidence-based, comprehensive, and integrated HIV and sexual and reproductive health service delivery. Mental health services are also important, as I mentioned in our emergency projects, and comprehensive HIV care packages for trans people. We also want to advocate for sustainability of supplies and commodities. So this is not just an HIV program problem, but a whole health network problem. And we've seen this in the last few years, and even during this pandemic, there is a delay in the delivery of medication. There's a delay in the delivery of commodities and prophylactics, condoms, PPEs. All of these are being delayed because the DOH supply and logistics department is not performing at a standard that is acceptable, even to the minimum standards of a health logistical framework. So as a community, we want to take on this challenge of really advocating for a whole system-wide reform in terms of ensuring that our procurement process and our delivery, supply, logistic process are world-class, and of a high standard that allows people to live and not waiting to die in their houses or in the clinics. The fourth one is a call for PhilHealth and DOH to continuously review and assess the adequacy of the OHAT package and to ensure standardization of OHAT package implementation. The OHAT or outpatient HIV and AIDS treatment package is not implemented similarly in different treatment hubs. So we want to make sure that that is standardized. And of course, we want to expand the coverage of that outpatient HIV and AIDS treatment package. Before you get to enroll in your ARV, into ARV treatment, there are some required tests that people usually pay out of pocket, and sometimes it runs from 8,000 to 20,000 plus, depending on the opportunistic infections that you may have. So we want to make sure that this is covered by the program. So I'm just gonna go through these very quickly. Clear guidance in responding to HIV in light of other emergencies, not just pandemics, but also natural disasters. We have to be resilient in terms of delivering health responses. And I think this goes for all health programs. COVID resilience service delivery networks, of course, that is a given. And expansion of social protection for PLHIV and KPs. And then the last one is, increased collaboration between LGU, CSO, CBOs on differentiated HIV service delivery. So in some places, it works better if it's the LGUs. In other places, the CSOs or the CBOs are a better partner in service delivery. And finally, this is the research agenda that we want to propose to make sure that our HIV programming and community agenda advocacy is relevant. So of course, strategic information on key populations, as mentioned by Dr. Imperial a while ago. The mapping of all policies that impact HIV response, the mapping of all sexual and reproductive health facilities, and the mapping of all HIV services received during this crisis. Yeah, I think that's the last slide. And so this is our community agenda for the next few years. Meron pa pala. It's mostly mapping, a lot of mapping that we want to do really. The only way for us to really move forward through the CBOs is to make sure that all of these projects that we are implementing are evidence-based and are made sustainable by putting them into the program. And we can only do that through PINA. Yeah, that's the end of my presentation, and I look forward to discussing all of these with you later. Thank you so much.
Thank you. Our next presenter is Dr. Susan Ku Vin. Professor Ku Vin is a professor of obstetrics and gynecology and medicine at the Alpert School of Medicine, Brown University, and professor of health services, policy and practice at the School of Public Health. She is the director of the Brown Global Health Initiative. She is the director of Providence Boston University Center for AIDS Research. She has been NIH funded since 1996 and has been the principal investigator of several researches to assess HIV dynamics in the female genital tract. She was a co-investigator of the CDC-funded study to understand the natural history of HIV in women, the so-called HERS, and the study to understand the natural history of HIV and AIDS in the era of highly active antiretroviral therapy. She had several researches, and she has been a member of several NIH review committees. She continues to provide care for women and men living with HIV. She works primarily in Kenya, Philippines, and Bangladesh, but collaborates with many other countries as director of the Brown Global Health Initiative. She is a graduate of the University of the Philippines School of Medicine, class of 1992, and did her obstetric and gynecology residency at the Philippine General Hospital before moving to Brown University in 1992. Professor Ku Vin will be discussing on moving forward in addressing the HIV epidemic through Brown University and UP Manila partnership. Professor Ku Vin, the floor is now yours.
Thank you. Thank you, Angie. And I hope you can see all my slides. And I'm going to talk about our relationship between Brown and the University of the Philippines. Next slide, please. We have a long history of collaboration between UP Manila and Brown University. This started more than 30 years ago by Dr. Charles Carpenter and by Dr. Ernesto Domingo. And the faculty at Brown, I met when I was at the UP Manila and the Philippine General Hospital in the late 80s when they came to establish an STD treatment course at the university. And this became stronger over the years. Then we applied for a Brown AIDS International Training and Research Program that lasted 20 years. This is funded by the NIH. Because of this program and the current D43 training program, we have funded and trained 31 Fogarty scholars over the 20 years. We have our long-term trainees who will come and do a master's or a PhD program here at Brown. Middle-term trainees will come to Brown for 3 to 6 months and do most of their work in the Philippines. And we have short-term training in terms of symposiums, conferences, workshops, grant writing, and manuscript writing workshops. In the history of this program, previous slide, please. In the history of this program, the Philippines was doing so well in HIV and AIDS. And so at a certain point in time, the NIH asked us to drop the Philippines from our AIDS training program because the prevalence and the incidence of HIV/AIDS in the Philippines was so low compared to all its other Asian neighbors. And so there were many years when the Philippines was no longer part of this program. Unfortunately, over time, as you have seen in the past, there has been an over 400% increased risk in the incidence of HIV and AIDS in the Philippines. And so we have asked the NIH, and particularly a D43 training grant by Donna Perario, to make the Philippines a focus of HIV/AIDS research again. Next slide. So currently, we have our D43 scholars through a D43 training grant. These are faculty from the University of the Philippines who come to Brown for their masters or their PhDs. So we have Adeline Lopez, who came in for a short-term, middle-term trainee and was the recipient of a Center for AIDS Research grant doing advanced clinical research in HIV prevention research methodologies. I work with Adeline. She joined me in my clinic. Our HIV clinic has 1,700 patients who are HIV infected. Amiel Bermudez is doing a PhD at the School of Public Health in Epidemiology, anticipating to graduate in 2023. Maria Irene Kilantang, I think you all know, is working in HIV violence against children and on HIV and mental health. She just completed her master's in global in public health and is starting her PhD at Brown. this fall, and so she remains at Brown, and Amiel remains at Brown. Olivia Simpson Season did an association of anticipated stigma and provider mistrust and the preference for HIV self-testing among men who have sex with men in the Philippines. And she just completed her master's in public health this year. Then we have Marilyn Palatino, HIV in biostatistics. She completed her master's in biostatistics this year. We have Calvin de los Reyes, who we have very thankful for really helping organize all these webinars. He's working on HIV-related stigma and health services, and he's a senior lecturer with a Master's of Health Philosophy Studies program at the UP Manila. And we have Christine Tamanan, who is also a current scholar doing HIV care and prevention in nursing, and she's an assistant professor at the College of Nursing at UP Manila. And Ryan de Torres, who is working on development and validation of adherence experience and the care and treatment scaling among HIV-infected patients. He is an assistant professor at the College of Nursing. So these are current scholars. Next slide, please. Here are our scholars at Brown, and this is Professor Donna Perario, and as you can see, our Brown Manila, UP Manila scholars, and that's Jennifer Nazareno, also a Brown faculty at the School of Public Health. Next slide. This is the graduation of Olivia and Irene during the commencement ceremonies at Brown. So they are carrying now the colors of Brown. These are the colors of Brown for the graduate school. And fortunately, this year, we were able to do an in-person, although with all the social distancing and everything, for a graduation, which we were not able to do last year. Next slide. These are some members of the Philippine Initiative for Research, Service, and Training, which we call FIRST. This was established by our Filipino students as well as Filipino students at Brown and faculty at Brown. You can see, all of us here and some members of the Brown community. This is Eileen Caffrey. She is the program administrator of our Fogarty program. She is the lifeline of all our Fogarty scholars. I think I can say that for our Fogarty scholars from all over the world, Eileen is the mother hen, or is the solver for everything from the moment she picks you up from the airport, arranging your housing, getting your social security, your ID, getting you access to everything, your stipends, the salaries, and everything else. Eileen is the key person. I don't think Dawn and I would have any Fogarty program that is successful without Eileen. So I would really like to acknowledge Eileen and all her contributions for our D43 training program. Next slide. So I think the challenges posed by the COVID pandemic is felt both in the Philippines and both in at Brown. You are again under lockdown for many of your activities. You have an ever increasing number of cases, although you continue to vaccinate more people. Unfortunately, in Rhode Island and in the United States, we were doing very well in April with a massive decrease in our in our COVID cases, with increasing vaccination. Unfortunately, with the Delta variant, which is 1,000 times more transmissible than the original COVID variant that we had, we are back to facing the pandemic. We have increasing number of COVID cases despite the vaccinations. We have reinfections, although mild and symptomatic cases and low prevalence among people who have been vaccinated, even 2 vaccines for COVID. But the biggest problem in the Philippines, in America, are the core people who refuse to be vaccinated. And for many reasons, particularly in the South, they just have a problem of accepting the vaccine. There is no right and wrong. I think it's their right to refuse the vaccine, but it's very hard to understand why, for the rest of the world who don't have enough vaccines and who are awaiting the vaccines, in the US, where vaccines are readily available, they will even come to your community to give you the vaccines. It's for free, so there is no cost to it. People are refusing to take the vaccine and taking medications. Like, we have a big problem right now with ivermectin, an antiparasitic drugs, mainly for animals, that are being used by patients more than to protect themselves from COVID, more than taking the vaccine. And we have increasing calls to the Poison Control Center because of all the people taking ivermectin. So anyway, we have all experienced disruption in research, training, and service. Last year, we were really just on virtual learning. This fall, luckily, we're able to open in person. I think 99% of the student body and the faculty and the staff are now vaccinated. We will continue to do weekly COVID testing, even if we are vaccinated, just to make sure that we are able to detect cases of COVID that are reinfections after vaccinations. So that will continue. Luckily, the university is able to afford free HIV testing for, I'm sorry, I keep on saying it should be COVID testing for everybody in the university once a week. And our governor has made it mandatory for all healthcare workers and universities to have faculty and students have COVID vaccine. So that helps us very much. We have had travel restrictions and quarantines, vaccination issues, ever-changing policies depending on where we are going with the COVID pandemic. I'm sure you have the same. In the last 30 years, I've been traveling 4 or 5 months out of the country for my grants and for my job. It's the first time in 2 years I have not been able to travel to any of the countries where I work with. And that has been a great change for me because of the lockdowns, and particularly most of the countries I work with are low and middle resource income countries that are now between level 3 and level 4 designation by the CDC, so I can't go to any of them. Education has been disrupted very much. Virtual learning has a lot of pros and cons, but it has replaced in-person learning. It's not perfect, but it's better. But the internet connection for many in the Philippines, I'm sure it's not the same all over the country, but even in the US, I can tell you that for students in more rural communities or who are economically disadvantaged cannot really access good Wi-Fi. Brown, who has quite an endowment, was able to supply computers and pay for Wi-Fi connections for students that are financially unable to do so, but many other institutions cannot do that. It's very expensive here. when I travel to the Philippines, your smartphones, you pay so little compared to what we pay here. Our smartphones, for limited data and no international calling, minimum is $70 a month. Our internet connections, even just for me, internet and just TV is $170 per month. So it's impossible for many of our patients. Then we have Zoom fatigue. We do a lot on Zoom and it's just very hard. Loss of the Brown experience because many of the trainees cannot come to Brown. They are able to come now. We're very lucky for that. Our safety, the safety of our trainees, their families, and the concerns of being away are very important to us. How to write grants, maintain our grants, maintain the progress and innovations is really very difficult during a COVID pandemic. Next slide. Next slide. So we are working with the Chancellor's Office at UP Manila and the Brown HIV/AIDS Center to develop a UP Brown HIV/AIDS Center. Donna Perario is going to recompete the D43 for another 5 years. We are enhancing the first program to go beyond HIV/AIDS research with the UP. We're increasing collaborations with multiple disciplines, schools, and departments at UP. We help enhance UP curriculum in HIV and AIDS. And the ultimate goal is to be able to develop leaders at UP Manila who will take over all these activities. Brown will not always be leading this. We are training so many of you so that eventually the D43 will be led by a UP Manila investigator. And recently, Donna Perario, Lawfred Hernandez, and Olivia Season have just been awarded an R21 grant for stigma reduction and gender affirmation to promote HIV prevention and testing in trans women. Next slide. With this, I would like to thank everybody, the NIH, of course, for funding us, UP Manila, the UP Manila Chancellor's Office, UP School of Medicine, Philippine General Hospital, Brown University, the School of Public Health, the School of Medicine, the Global Health Initiative, and the Providence Boston Center for AIDS Research, and the community organizations and all the patients that make this work possible. Thank you so much.
Thank you, Professor Ku Vin. So we now go back to our previous speaker, Director Oresca.
Okay naman. Bakit wala?
Ma'am, you can start na, nakikita ka na po.
Paano mag-i-start? Wala
Hello
naman.
po. Director Maria Luisa, we are on live na po. We're being live streamed.
Ha?
Ikot ma'am yung video. Patingin ma'am ng video, naka-off video ka.
Okay. Okay, good afternoon. Yeah, good evening. It's already 6:25. Okay, Ryan, may I start?
Yes, please.
Yeah, good evening. I'm Director Maria Luisa Oresca of the Philippine National AIDS Council Secretariat. And I'll be discussing with you or presenting to you the post-pandemic Philippine HIV and AIDS epidemic response of the country. Next slide, please. Okay. As you can see, I'm expected to discuss with you tonight the move forward in addressing the HIV epidemic through the national and local government initiatives. Okay, next slide, please. We know pretty well that in the presence of RA 11166, otherwise known as the Philippine HIV and AIDS Policy Act, the Philippine National AIDS Council is mandated to do the country response through the 6th or the AIDS medium-term plan. Okay, next slide, please. And this Republic Act, Article 2, Section 19, really speaks about the HIV and AIDS education in the community. It is being headed by the Department of Interior and Local Government as the national government, and the Union of Local Authorities of the Philippines, or the ULAP, League of Provinces, League of Cities, and the League of Municipalities through the Local AIDS Council, or the LAC, or the local health boards in coordination with PNAC shall implement a locally based multi-sectoral community response to HIV and AIDS, and speaks also about the Gender and Development Fund may be utilized for this purpose. And the third of which is indigenous people communities and the GIDA, or the geographically isolated depressed areas, shall also be given due focus. Next slide, please. Also, to ensure the funds, what most of us are concerned with, it has an Article 8, which speaks about Section 52, to be specific, the Department of Budget and Management, representing the national government in coordination with the Department of Finance and the Department of Health and other relevant government agencies, shall consider the incidence of HIV and AIDS in determining the annual appropriations for the implementation of this act in accordance with the AMTP, or the AIDS Medium-Term Plan. And next is a separate budget in the LGUs, or their local government units, shall be allocated for their action plans specified in this act. Next slide, please. Now, this is what we're doing, okay, in addressing the HIV epidemic through the national and the local government initiatives. First of which is the advocate LG officials to implement RA 11166. What we do is we engage into dialogues with the different officials of the LGUs, and just to remind them of their mandates as partner of the national government in response or addressing our response of the country to HIV and AIDS. Next is strengthen coordination between the LGUs and the CSOs in the delivery of HIV and AIDS-related services. We're expecting the local government units to coordinate or partner with the CSO within their catchment areas, so that both of them will be providing the services needed by our communities, the PLHIVs. Okay. Next of which is to encourage the use of online platforms. When we speak about this, we are referring to Messenger, Facebook, Viber, Zoom, etc. We know for a fact that because of the new advanced technology in in communication, this PLHIV community is very active in communicating among themselves through these several platforms. So we believe that by using these platforms, we could address their concerns and issues, and we could easily respond to their needs. I know for a fact that some of the communities have the gay apps, like the Grindr, the Blood, and they have the Twitter, they have the alter account, the so-called subculture, I think. And then that is exclusively for, that is exclusive rather for gays, where they have their parties, the selling of sex toys, drugs, poppers, whatever they need, okay? And then these things are being done, okay, through these online platforms, okay? And last of which is strengthening of the PLHIB call center. I wish to commend Pinoy Plus because they have this, where they call it response centers, and they cater to that community on regarding their issues on testing, the ARV provision or access, and the support group where they could, verbalize whatever feelings they have, their thoughts and opinions on what is happening among them, okay? Like Mr. Benedict Bernabeu, I think, made mention of their several concerns, and I took note of that because he deliberately said that of the mandates of the PNAC, they are expecting things to be done, and well taken for that, Mr. Bernabeu, okay? And what we're doing, we make sure that upon the issuance of the guidelines on how we could really be efficient in providing services that they need, or the so-called PLHIB community, we are expecting to collaborate with existing network community-based organizations in promoting the HIV and STI services of health facilities, including access to condoms and lubricants, HIV screening and testing and treatment. And we ensure uninterrupted access to vital health services such as life-saving ART to protect the health and safety of persons deprived of liberty with HIV who qualified for early release in prisons or jails. Promote HIV and STI services through social media application, try media in virtual channels. That means online outlets or broadcasting networks and newspapers, magazines, and publications. Support conduct of outreach activities by community health outreach workers, peer educators, and volunteers, as long as they are provided appropriate PEs for their protection. We are in the midst of this pandemic. And then intensify facility-based HIV screening in rural health units and HIV facilities, such as social hygiene clinics, primary HIV care clinics, and HIV treatment hubs. Expand availability and access to rapid HIV diagnostic algorithm, especially in DOA's regional hospitals, existing primary HIV care clinics, and social hygiene clinics of category A cities. For regions with low HIV burden, RIVDA shall be prioritized at least in one laboratory per province. Conduct close monitoring and reporting of ARV and other commodities based on timelines set in the department memorandum and directory of DOH designated HIV treatment hubs and primary HIV care facilities in the Philippines. Engage in telemedicine services with PLHIB and clients from the key populations with no prejudice to quarterly physical pickups of ARV by PLHIB to ensure their health status is assessed, and especially from other life-threatening conditions such as tuberculosis and HIV treatment failure, among others. Okay, provide electronic travel pass to PLHIB or community-based HIV screening provider or HIV case management to facilitate movement of individuals in case of localized lockdowns due to resurgence of COVID-19. They had facilities to ensure continuous access to ARV, including use of available courier services, hospital or LGU vehicles, and transport network vehicle services for pickup and delivery of ARVs, as well as engagement of partners from community-based organizations for ARV access points. Coordinate closely with HIV viral load testing centers for a seamless referral of PLHIV for their scheduled viral load test. Collaborate with other government and private sectors to provide additional HIV prevention to key populations and care and support services. So the PLHIV must be exercised to enable them to cope with the prevailing situation and adjust to the new normals. Okay, these are all we are adhering to, so that the PLHIV communities will be properly provided with the services that they need. Okay, thank you. That's the end of my presentation.
Thank you, Director Oresca.
Yeah, thank you.
To give a short message, we welcome Dr. Kyohiko. Sorry. Thank you, Director Oresca.
Yeah.
Okay. So, for a short message, we welcome Dr. Kyohiko, Professor Kyohiko Izumi. Dr. Izumi is the Technical Officer for HIV, Hepatitis, and STI of the World Health Organization in the Philippines. Dr. Izumi has, in the last 5 years, Professor Oresca, kindly mute. Yes. Okay, thank you. He is currently based in the Philippines, working as Technical Officer of the WHO for HIV and viral hepatitis. He also performed the same function to include tuberculosis at WHO in Laos. Before that, he was WHO temporary advisor and short-term consultant in Myanmar. His various other postings for the WHO include Papua New Guinea, the Solomon Islands, Mongolia, and Sudan. In Japan, he worked as senior researcher in the Research Institute of Tuberculosis from 2013 to 2019. Dr. Izumi has also authored and co-authored peer-reviewed publications on tuberculosis and respiratory diseases. Let us welcome Professor Izumi for his special message.
Thank you. Can I share my screen? Can I share my screen? Maybe Chair, could you stop sharing? Okay, now I can.
Okay.
Yeah.
Thank you.
Thank you. Okay, thank you, Chair, for your kind introduction. Good evening, everyone. My name is Kyo from the WHO Philippine Country Office. I'm very pleased to have this opportunity to speak to you today. In this presentation, I would like to talk about how we can respond to the HIV epidemic during and also after the COVID pandemic. So as we know, the Philippines is one of the high HIV burden country with rapid increase of new infection. So Epidemiology Bureau reported that the estimated PLHIV is 115,000 in 2020. So among those, around around 48,000 PLHIV are on ART, but around 30,000 PLHIV diagnosed, but not on ART, due to the several reasons, lost to follow-up or failure, and around 36,800 PLHIV have not been yet diagnosed. So this means that more than 67,000 PLHIV are not receiving ART, so which leads further transmission in the community and advanced HIV disease, and also increasing mortality. So we estimate that we need to increase diagnosis from current level of 1,000 case finding per month to 7,000 case finding per month, and increasing uptake and retention to the ART in order to achieve national target by 2023. However, COVID pandemic is heavily affecting on the HIV service delivery throughout care cascade in 2020. The number of HIV tests decreased at 61% nationwide in 2020. Number of HIV confirmed decreased at 37%. ART initiation dropped at 28%. And these disruption of service deliveries affect on the HIV epidemiological trends. And therefore, we really need to transform our approaches of HIV response under the COVID pandemic. So I would like to highlight priority measurements. So HIV testing needs to be provided through new modalities such as HIV self-testing, partner and social network testing, index testing, which will be included in the updated national guidelines, which will be released soon, and in order to increase the uptake of the HIV testing. So live confirmatory testing needs to be decentralized to all treatment hubs rapidly to shorten turnaround time to same-day results. So previously, the majority of the HIV confirmatory testing was very centralized in the HIV National Reference Laboratory. It took around 1 month turnaround time. However, if you introduce LIVDA nearby the clients, then the turnaround time dramatically decreased to 2 to 3 days. And sharing GeneXpert platforms to the HIV viral load testing is a key approach to decentralized viral load testing, so which will help early detection of treatment failure and also drug resistance. So for HIV treatment, rapid transition to the TLD as first-line regimen is important. So it is more potent, better tolerated, and higher resistance barrier. The same-day ART can increase treatment uptake, the viral load suppression, and the retention rate. Multi-month dispensing for 6 months or more can reduce frequency of the client visit. As for the service delivery, so virtual interventions can facilitate service delivery, for example, online outreach and the referral, online booking of the testing and treatment, SMS reminders for drug taking. And one-stop shop facilities can provide a comprehensive HIV and relevant services nearby at one place, so which will reduce unnecessary patient travels. And also, striders can be collaboratively used for the specimen collection and the commodity transportation of tuberculosis, HIV, and other diseases. In the end, HIV adaptive measurements needs to be implemented every health facilities. So this includes integration of HIV prevention activities within the COVID-19 response and ensure infection prevention and control. Promotion of COVID-19 prevention and vaccination literacy and uptake is also very important. And the congestion of health facilities can reduce the risk of exposure. For example, appointment booking, flexible opening hours, one-way patient flow pathway, and triage of clients. So these priority measures that I highlighted here are applicable to HIV response, both during COVID pandemic and also post-COVID pandemic era. So that's all from me. Thank you very much for your attention.
Thank you very much, Professor Izumi, and to all our speakers. Since we are already on overtime, we will have a question for all our speakers. May we request our speakers to please turn on your videos? Okay, thank you. So in your respective organization or sector, how can the Philippines achieve the global UNAIDS HIV targets of 95, 95, 95 during and aftermath COVID-19 pandemic? Can we start with our first speaker and the succeeding speakers? Yes, Professor Imperial.
What may be necessary is for translational research. I mean, in the academy, for example, we do research, but this has to be translated to, as I was saying in my presentation, to operational details, so that the users of the outcomes of this research will be able to implement this in their respective settings, whether this be institutional or whether this be communities. So I think that is what is one of the more important things that we have to do.
Thank you, Professor Imperial. Maybe we can go to Ben.
I agree with Dr. Imperial. I think it has to be an integrated approach. And that is actually what is mandated by law, a multi-sector response to HIV. We have seen in the last few years how a siloed response to the epidemic has not worked. So you really have to make sure that the research feeds into the policy and the programs. And the policy and the programs also deliver feedback in terms of monitoring and evaluation that becomes part of research. So that way, the response becomes organic and multi-sectoral, and we don't respond just within our sectors, but we respond as a whole, as a whole country, a whole government approach to the HIV epidemic.
Thank you, Ben. Director Oresca.
That all of us should be working together so that there will be no stone left unturned. Okay, the expertise of each one of us should be put together, and all the stakeholders should be working hand in hand so that each of our own expertise will be put into that, and more effective and efficient and response will be given to our community. Thank you.
Professor Ku Vin. You're on mute. Kindly unmute.
We all have the right tools. We have all the SOPs in paper. I think there's enough thought that has been given to it in terms of response in paper and in meetings and everything. I think realistically, we are living with the pandemic. And for most people, for all of us, including our families, dealing with the pandemic right now comes as a priority. Our safety, the economic repercussions of the pandemic, the politics that go with it, it's everyday life survival. And I would like to believe that we will be able to ideally implement and work as a multidisciplinary group despite what is happening in the pandemic. But in reality, we know we have had a setback and we have to accept the setback. There is no way that we were progressing the same way we are progressing now with the pandemic. I really think that we will have a time for recovery. We will have to live with this pandemic, whether we can take care of it or not. But to be honest, right now, we have all our HIV priorities, but it has to be mixed in with the reality of the pandemic. And I am sorry to say that even for us in resource, rich countries, we are having a difficult time maintaining everything that we would like to do ideally. It's just the reality of things.
Thank you, Professor Ubian. May we hear from Professor Izumi?
Thank you, Chair. I believe that the most important
Yes,
approach.
Professor Usini. Okay.
Oh, sorry. Can I say something?
Yes, we can hear you.
Okay, thank you. So I think I believe that the most important approach is decentralization of the services. I already highlighted, and also other presenter highlighted some of the example, like confirmatory testing, LIVDA, which is a rapid HIV diagnostic algorithm. Only 26 LIVDA sites in the country, but we are aiming to expand this to the these services to the 150 treatment hubs, and also viral testing. We have only very limited number of the viral testing, so that only 17% of the PL-HIV on treatment have opportunity to have the viral testing in the country. Even the viral suppression rate is more than 95% among those who have a viral test, but the test coverage is really low. So we really need to decentralize. So one of the opportunity is the gene expert machine for the viral, originally used for the tuberculosis diagnosis, but that platform can be used for the viral testing for the HIV. And also the UHC transformation in the country, ongoing transformation is really important, and the integration of the HIV services to the primary health care, and also the health information system integration and the laboratory system and logistic management system is going to the integration manner. So this is really a good opportunity for us to piggyback on the mainstream of the government health reformation. And in addition to this effort, maybe the virtual intervention, online platform usage will be another opportunity. Over, thank you.
Thank you very much to all our speakers for the very vital inputs. We now go to the awarding. So for the awarding of the certificates, let us go to the first certificate. So this certificate of appreciation is presented to Ms. Maria Luisa Oresca for sharing knowledge and expertise as a speaker during the 5th session of the HIV and COVID-19 webinar series, Next Steps, the Post-Pandemic Philippine HIV Epidemic Response, given this August 28, 2021, signed Dr. Carmencita Padilla, Professor, University of the Philippines College of Medicine, Chancellor, UP Manila, and Dr. Don Operario, Professor, Brown University, Director, NIH Fogarty, the training program for the prevention of HIV in vulnerable populations. For the next certificate, the same appreciation is awarded to Dr. Reynaldo Imperial of the University of the Philippines, Manila. The same certificate of appreciation is awarded to Mr. Benedict Bernabeu of the Red Whistle. Next, please. Next, please, Calvin. The same certificate of appreciation is awarded to Professor Susan Ku Vin of Brown University. Next, please. The certificate of appreciation is also presented to Dr. Kyuhiko Izumi of the WHO Philippines. So let us give all our speakers a round of applause. Okay, and now next, for our closing remarks. Next slide. To close the webinar series, may we call on the Vice Chancellor for Academic Affairs of the University of the Philippines, Manila, Nimia Pimentel Simbulan.
Thank you very much, Dr. Mirasol. Good evening to everyone. So we have reached the end of our webinar series. We have successfully completed the 5 webinar series on HIV and COVID-19, a collaborative endeavor of UP Manila and Brown University. I believe you will agree with me that the choice of HIV and COVID-19 as the theme of the webinar series was not only timely, but relevant as well. While the world continues to struggle in controlling the spread of the COVID-19 pandemic to prevent the further escalation of cases of those infected and affected globally, we take cognizant of other public health problems and challenges faced by countries worldwide. In the Philippines, one of these is the HIV and AIDS pandemic. The webinar series was an opportunity to present and clarify many issues, concerns of various stakeholders on these 2 public health crises in the country. The 5 sessions provided much needed venues for experts, researchers, health professionals, NGO and community-based organization workers, PLHIV, and the general public to share their knowledge, experiences, insights, challenges, calls, and aspirations on HIV and COVID-19 pandemic. Allow me to recapitulate the 5 webinar sessions and what have been covered and accomplished. Webinar session 1, COVID-19 and the HIV Cascade of Care, allowed healthcare agencies and institutions like the Department of Health, San Lazaro Hospital, and community-based organizations like Love Yourself share the challenges posed by the pandemic while aiming to deliver health services to PLHIV in a sustained manner. Webinar 2 on the ground COVID-19 narratives and realities of the PLHIV community gave PLHIV a venue to present stories of the demands, difficulties, and problems encountered in accessing much needed treatment, services, and support in the midst of the COVID-19 pandemic. Webinar 3, Who is Next in Line? Considerations and Guidelines in Vaccinating the PLHIV Community, on the other hand, provided health professionals an occasion to shed light on the issues and concerns accompanying the COVID-19 vaccines and emphasize the importance of the PLHIV community accessing the COVID-19 vaccination program of the government. Webinar 4, Communities and COVID-19, was a venue for representatives of CBOs like the Association of Positive Women Advocates Incorporated and Love Yourself to share the innovations, good practices, and adjustments taken by the PLHIV community, CBOs, in response to the numerous challenges and difficulties posed by the pandemic in carrying out their mandates. And finally, Webinar 5, Next Steps, the Post-Pandemic Philippine HIV Epidemic Response, with representatives from the government, academe, CBO, and research institutions sharing their perspectives, lessons, and recommendations in reshaping and improving the HIV epidemic response of the country. I'd like to extend my congratulations to the UP Manila Brown University organizing team, primarily Ms. Eileen Caffrey, Mr. Calvin de los Reyes, and Mr. Ryan de Torres in collaboration with the UP Manila IMS staff, as well as the session facilitators and resource persons for their valuable contributions in making the webinar series on HIV and COVID-19 a success. I also like to thank all those who joined us, who attended the webinar series and actively participated in the open forum of the different sessions. Again, congratulations to everyone and thank you for joining us during the 5 webinar series of the activity conducted by UP Manila and Brown University.
Thank you, Vice Chancellor Simbulan. Next slide, please. Do we have the next? Okay. Please follow us on our social media accounts for updates on our projects and programs, like our Facebook page, the UP Manila Brown Webinar Series, and follow us at Twitter at UP Manila Brown Webinar. We wish to thank our media partners, Sav, Selfie, and Report R. Next slide, please. We appreciate your feedback. Please answer the evaluation form on or before August 29. You may scan the QR code flash on the screen. Access the link provided, so it would lead you directly to the online evaluation form. Certificates will be issued to those who accomplish the evaluation form, but allow about 3 to 5 days for the certificates to be issued. We will not be responsible for undelivered certificates due to wrong email addresses. So make sure that you provide the accurate email addresses. So on behalf of the HIV and COVID-19 webinar series organizing team, thank you for joining us. Marami pong salamat. Good evening, everyone. Keep safe.
Recording stopped.
Sir, cut tayo sa live stream.
Hear me?